Okay, hi everyone. Thanks for coming to the August webinar. So firstly, I would like to begin by acknowledging the traditional custodians of the land that we're all meeting on today and pay my respect to the elders past, present and future. I also acknowledge my gratitude that we share this land today, my sorrow for some of the costs of that sharing, and my hope and belief that we can move to a place of equity, justice and partnership together. So thanks everyone for coming, and we'll kick off with Matt Anstey, who's presenting on the Blood Cultures Project at Sir Charles Gardner Hospital.
Thanks, Anne-Marie. It's nice to be presenting this work. So this isn't a specific choosing wisely item that I don't think any college has written before, but choosing your blood cultures wisely is obviously an important thing. And I'll show you a little bit of the background of why we took this on, as well as what ended up happening. So on one side, blood cultures are obviously really helpful to tailoring antibiotic therapy, and patients who have positive blood cultures that aren't contaminants are associated with high illness severity, and that helps tailor diagnosis and treatment, which is beneficial to patients. On the other side, though, blood cultures, there's a significant number of false positives, and every positive result exposes more patients to antibiotics, and more exposure means more resistance, and also potentially complications from antibiotic use. And extra blood draws themselves, because blood cultures take quite a lot of blood from a patient, associated with pain and blood loss. So this is some data from WA Health, 2017 data. Of the 52,000 blood cultures sent to PathWest, so the public system, diagnostic yield was about 6.5%. And you probably know that blood cultures, when you take a set of blood cultures, you should really take 2 sets to increase your diagnostic yield. But in about a third of those, we were only taking 1 set. And we were repeating cultures in a lot of times, and this is where a lot of our work ended up focusing on. We repeated cultures probably in a quarter of those. And contamination rate was relatively low, but still not insignificant. 2,500 patients end up getting exposed to antibiotics and recalled, or whatever happens with those contaminated blood cultures. So in Charlie's, we had about 14,000 blood cultures in a calendar year, which is actually small when you think about how many full blood pictures taken, 225,000. But the blood cultures themselves, as I said before, are high yield, and they have a diagnostic pathway that you follow through if you have a positive blood culture. So when we thought that we would try and tackle the blood cultures in the hospital, there were 2 anecdotes that we heard. One was that if you are an inpatient and you have a fever, then often the nurses will call the residents to come and take a blood culture from that patient. And that's regardless of whether the patient is deteriorated or not, and regardless of whether they've been on antibiotics or not. So we wanted to try and ascertain in our patients, and specifically in the hematology oncology patients, so they're the ones at highest risk of problems of undetected bacteremia because they have no immune system, what was happening in those patients. So we had Ardash and Sarah collect a whole lot of data, and I'm just about to show this to you. In these patients, because they go on this febrile neutropenia pathway, they have a lot of repeat blood cultures taken. That was the anecdotal thing, that if you're on after hours, they have a fever, you get asked to go and take some blood cultures. These patients are already very sick, and so people are worried about missing something. International guidelines, how many blood cultures is appropriate? Usually 2 sets in the evaluation of an aseptic episode, and there's a volume of blood that's correlated with positivity. And beyond that, extra cultures don't seem to change management or enhance bloodstream infection detection. So they tried to answer these questions. How many blood cultures were being performed per patient admission? What happened for those who got multiple repeat blood cultures? And did those repeat blood cultures alter outcomes? So this was about a 3-month period. And as you can see, in 3 months, that's quite a lot of blood cultures taken from a small number of patients. This is some of the sort of modifying factors, so whether they were neutropenic or not, and whether they had a line or not already in. So for the oncology patients, of those 243 sets, 18 were positive. And from the hematology patient, 477 sets were taken and 21 sets were positive. So sort of 4 to 10% rates positivity, which sort of fits with the international literature. And these were some of the organisms identified, and then some were isolated multiple times. And then you can see the ones in red are ones that are thought to be contaminants, so skin species. And then this is the number of blood culture sets taken per admission, so this is per patient. So as you can see, from 3 upwards, there are patients getting multiple sets. And so, you know, there were 4 patients who got more than 11 sets of blood cultures for an admission. Also, we talked about before how ideally we want to be moving to this 2 sets of blood cultures being taken. Predominantly, they were taking 1 set, which makes it difficult when you only take 1 set from 1 site to know whether that, if it's positive, is a contaminant or not. So we sort of had 2 tails there that we were interested in. For these patients who had multiple sets, so I don't personally think that I would have liked to have had 15 sets of blood cultures taken in an admission. All the cultures were negative from those top ones there. And then as you can see, as it goes down, essentially the first sets of blood cultures were positive and the subsequent ones didn't add anything to the diagnostic yield for those patients. So it appears that this suggests that repeating blood cultures in patients who've already had some appropriate ones taken and who are on antibiotics doesn't change management. There were a few cultures that were positive late in patients. And when we looked at those, there were 2 patients that came positive after day 5 of admission. And in both of those patients, the important thing to note is that they had a clinical deterioration in that setting. They became hypotensive and febrile, and again, hypotensive and febrile. So there was not just a fever as a trigger, but they had changes to their physiology that signaled that they had a deterioration and would be an alternative reason for taking blood cultures rather than just a fever. So a lot of blood cultures were done. They're often neutropenic and have indwelling lines. Some patients were being excessively cultured, and there did not seem to be a benefit to repeat cultures in the absence of clinical deterioration. But interestingly, there's this other tail where potentially some patients were not getting their appropriate 2 sets at admission. So ideally, try to work on that number there and move the 52 into the 36 column, and also reduce that repeat set. That'd be a huge burden if you're an inpatient having that many sets of bloods taken every day from you. So that work was done to basically answer any criticisms that may arise from having started a guideline and not thought about the sickest patients, the most vulnerable patients in the hospital. So if we thought that a guideline would work in the hematology oncology patients, then it would probably work in all the other settings. So we set about creating a guideline to look at what was the appropriate trigger for blood cultures and what was the current trigger. So it depends on where the patient might be. So if the patient's in the emergency department, there may be a different trigger because they have usually no previous antibiotics. They're not already admitted on some sort of treatment. And there's actually a pretty good decision tool called the modified Shapiro tool that can be used in that situation. If you're on the ward, that might be different. They may already have been treated for a period of time and they may be stable, or they may be deteriorating, suggesting a new infection. When to take blood cultures may also depend on the patient factors such as immunosuppression and what prior exposure they've had to antibiotics. So we created a new guideline, which I'm not going to show you the guideline per se, but this poster was created to supplement the guideline on the wards. This is the arm of one of our emergency physicians who nicely mocked up having had 8 blood cultures taken from his arm, and showed what it is actually like to be a patient to have had that done. And our culture guideline says that fever may suggest infection, but is not predictive of positive cultures. When to take cultures, when a patient has altered physiology, so that's hypotension, altered mental state, altered respiratory rates, and you only repeat it if there's deterioration suggestive of a new infection, unresponsive to therapy, especially if it's been more than 3 days. We also wanted to add in some things about how potentially we could improve our blood culture accuracy and reduce our contamination rate. So where to take them from aseptic technique, and try and encourage more than just one set, so 4 bottles for each one. So that was the sort of summary of the guideline that we came up with. And this is these are the sort of the take-home points that were taken out of the guideline. And really trying to push back against people just being asked to come and take blood cultures for fever alone. The pathway for the emergency department, there's a sepsis pathway, and we wanted to just to piggyback off that. The modified Shapiro tool is a very good validated tool, but is quite difficult to keep in your head. We did an audit of the emergency department blood culture use, and we realized that they could reduce their blood culture contamination rate and unnecessary taking if they stuck to probably 2 things. One was if they're not admitting the patient to avoid taking blood cultures, because it leads to difficulty tracking down the patient and working out whether it was clinically important or not. And also there seemed to be still a proportion of patients receiving blood cultures for what was apparently a viral illness, but the person was in the emergency department with a fever. Again, the febrile neutropenic patients we talked about before, and we tried to also stress that if patient had an indwelling line, then one set should come from there, plus a peripheral access set at the same time. And then, so the recommendation was for when to take, and then when to repeat. How to take, and then this down here about clearance of bacteremia. It was quite interesting undertaking this whole pathway, in that all these different things popped up where there was these sort of historical things where people talked about you needed to clear the bacteremia before certain things happened. And I have a slide later, but I'll talk about it now. We found out that the PIC service was suggesting to people that prior to a PIC line being placed, they wanted a negative blood culture. And they said that was because that was what infectious diseases wanted. But infectious diseases actually said, no, they didn't want that, and they didn't know why that was happening. And so we were able to clarify that with both groups, and now we have a guideline that says that unless infectious diseases specifically ask for clearance of bacteremia, such as in infective endocarditis, then PIC lines can be placed in any patient without second clearance blood culture. We obviously spent some time talking about filling the bottles, which one first, and also labelling the bottles appropriately to try and help the lab so that they could know which site things came from, which helps with determining if you get multiple bottles positive, whether it is likely to be a contaminant or not. Also to fill the bottle as much as possible, and the ideal spot is 10 mils per bottle. The blood culture guideline has ended up on our intranet page, and so that is sort of the point where for ongoing sustainability it is found. We embarked in terms of education on quite widespread education across the hospital. We've done a grand round. We've done multiple teaching to the after hours doctors and also to the different departments that were high blood culture orderers or senders. The take-home messages were that, you know, we can do better early, we can take less blood cultures later, and the predictors should be really suspicion of physiology, infection and altered physiology. We really need to label our specimens better. This is what I talked about before. An unintended benefit was this unofficial guideline that it was sort of miscommunication that was leading to a lot of extra work at both ends. So this is just a quick evaluation of where we're at. So the numbers down the bottom is months since I think June last year is number one, and number of blood cultures per month for the hospital. And as you can see, it's sort of ticking along between 400 to 500 there. Our intervention and in terms of education pathway and trying to change the prompts for nurses on the ward happened at that red line there. So I would say it's a bit early to tell. You always have an eye of optimism when you look at these sort of run charts, but you know, probably a bit early to tell at the moment. And it may be that these numbers obviously fluctuate with the volume of patients in the hospital. When I sort of correlated this number to the number of full blood pictures done, it was the trend looks exactly the same. So the volume of patients hasn't changed a lot over those months. We had, if anyone's thinking of putting this sort of work into their own hospital, we had a quite robust working group. So we had one of our emergency physicians who actually also pushed quite hard for us to try and make sure that things were shared between hospitals, because he teaches a lot of the medical students and finds that sometimes it's frustrating when medical students get different information in different places. So we had a look around at the different guidelines around town. We had one of our hematologists, oncologists, head of infectious diseases, some of our infection control nurses, and then junior medical staff as well as our sort of support project officers. At the time, it was Gemma. So quite a big working group, and this work probably took 2 years to come up with those sort of 3 simple points to take away with, but hopefully will lead to some change with how we do blood cultures in our hospital longer term. I'm going to stop there so that there's plenty of time for people to ask questions.
Thanks so much, Matt.
No worries.
You have a couple of questions already in the chat.
Okay, so Ian's question, our ID physicians ask for serial blood cultures in staph or E. coli bacteremia. So this is an interesting question. So ID physicians that at our hospital got consensus, and they said with staph, they only want serial blood cultures to know once it's clear, so they get the treatment duration for endocarditis or whatever. You start your 4 to 6 weeks from that point of clearance. They don't think that E. coli bacteremia needs to be, you know, if you know that it's sensitive, it should be done, and you shouldn't need negative cultures in those patients. Yeah, I'm not entirely sure. Explain negative cultures in patients after first positive sets. I think that's just that negative cultures means that they've responded to treatment, I would have thought, in those patients. And the Shapiro tool is validated for the emergency department. Yes, if we could embed it and populate it, that would be very useful. Our hospital is a long way away from being able to embed anything into any electronic medical record, but that tool is very useful. I think it is difficult for clinicians to hold that tool in your head because it's got quite a few different parts. If I resume sharing, I can show people what that tool is actually. This is the modified Shapiro tool. So you can see you've got things that you probably have available to you in the emergency department quite easily, but not necessarily all at the same time. Those bloods might come later than your initial triage when you're taking your bloods, and then do you go back then and take your blood cultures? Often in the emergency department, you take your history and you take all your bloods at one point. So that might be one difficulty in enacting that. But yes, you're right, it's a useful tool. Could the height of the temperature influence the decision to take cultures? So I think that is controversial. I think we were saying that temperature itself is weakly predictive of positive blood cultures, but there are other features that you should take into account. So our reading of the literature was if you just have a fever by itself, then that may predict positive cultures. But if you have that plus altered physiology, it's much more likely. And the fever itself is the time frame. Often the patient's positive bacteremic time period is prior to them spiking the fever. So the height of the fever might make you think this is more likely to be a bacterial infection and then make your decision to take blood cultures. It might change that, but it doesn't actually predict the positivity. Actually, fever, chills and rigors are much more predictive than fever itself.
And there's just one more from Brendan in the chat as well, Matt.
So do we have involvement of our micro lab? So we can get just that trend data that I showed you. So there is a project that someone in Perth is doing a PhD on to try and work on this PathWest data to give more granular feedback. So we don't get the adequacy and fill of our blood culture bottles. That would be really useful. And I think it would also be useful to get this data sort of correlated to volume of patients that are coming through. At the moment, it's sort of pretty, it's not very detailed data that we can get, but the lab does provide us with some information to give us trends. But your question is very pertinent in that we want to get the appropriateness of blood culture data, and just trend lines is not enough.
Right, any other questions? Just while we're waiting, Matt, can you talk to us a little bit about sustainability plans for this project?
So our hospital's introduced an after hours service, which is now its own department. So the residents after hours get dedicated teaching, and then they come under sort of the governance of a consultant. And we found that anecdotally, a lot of the repeat blood cultures were happening at a nurse trigger after hours. Patient febrile, please take blood cultures. So we've worked the education into their revolving education process. And the other thing I think from a sustainability point of view is that we have the working group pretty much had feelers or was working on all the high yield areas. So hopefully the working group maintains that enthusiasm in those places. We also aim to monitor the trends, and we're actually going to re-audit the hematology oncology data to see whether that's changed.
Thanks, Matt. Any last minute questions? Okay, thanks so much. That was a great presentation, and I think the approach to look at your most vulnerable patients was really impressive as well. Scott, did you have any updates from Choosing Wisely?
Hi, everyone. Thanks, Anne-Marie, and thanks, Matt. The only thing I was going to mention is that we are starting to plan for the Choosing Wisely national meeting for 2022. We are planning that it will be a face-to-face event. Hopefully, we'll be past where we are now with lockdowns and not being able to travel, but we're being optimistic. But I guess I know many of you are key attendees at that meeting. And so if there's anything either now or over the next couple of weeks that you, topics that you'd like us to be exploring or possible themes for that meeting, please let us know. We'd be very interested in hearing those ideas, and particularly what you're interested in and what's relevant to you and your work.
Great, thanks, Scott. And we're getting in early with Choosing Wisely Week for next year. We're hosting it starting on the 28th of Feb, so it'll be the first week of March, and more information to come as well. I think on behalf of the other Champion Health Services, Matt, it would be, I think a lot of them would like to have a look at your resources as well, so I'll touch base with you after in relation to the guideline and poster.
Pleasure.
Okay, thanks everyone.